Шановні колеги, прошу зайняти ваші місця. Окей, шановні колеги, починаємо найважче засідання після обіду. Я сподіваюся, що ви випили каву. А якщо не випили, будете мати коротку перерву між лекціями. Отож, сподіваюся, що у вас з'явилися нові запитання, рефлексії, переживання, думки. І я вже деякі чув. Будемо разом над ними працювати. Отож, доктор Ноа Філіп продовжує лікування ПТСР, використовуючи транскраніальну магнітну стимуляцію.
Okay. Great. All right. So welcome back from lunch. This is still me. And I would say, just while this is up here, so there's two logos here. One is brown. That's where I'm from. That's my university. The other over here is what we call our Center for Neurorestoration and Neurotechnology. And this is at our Veterans Hospital. And what we do there is really three different parts. And there's some feedback here. Is this painful for just, it's very loud? No, okay. Volume is okay for everyone? Yeah. Okay. So in our center, there's three parts. One part is related to mental health. So what we're talking about here, that's the part that I direct. We have two other parts that are relevant to what goes on here in Ukraine as well. So we do a lot of work with brain-computer interface for people who have spinal cord injuries. And intelligent prosthetics, so prosthetics that are plugged into the brain. Not quite yet ready for wider scale use, but it is certainly something that is being worked on heavily, both by us and a network of individuals who are in this space. And we have some early experience in the brain-computer interface world in terms of starting to figure out how to disseminate that work once it's able to be safe to do so. So those are topics for another time. But I think there's a lot of opportunities for us all to be thinking and working together for the years to come. These are my disclosures, which we saw earlier. Okay, so this is what we're gonna be doing over the next little bit of time. I'm gonna give you a little bit of a kind of a background on the sort of work that we've been doing using transcranial magnetic stimulation for post-traumatic stress. I'm going to walk you through a handful of studies that we've I have done or other people have done. We're really developing the use of TMS for post-traumatic stress. What I'm also going to do is walk through our clinical workflow. So what a day in the life of the clinic when we do different kinds of approaches. And then I'll end up with some sort of concluding thoughts, bring it all together. So I spent that last hour and change talking about how TMS works for depression. There's some various citations here. This is myself with one of our U.S. cabinet member for Veterans Affairs a number of years ago. Where as we were starting to roll out this large national program, people were getting very interested in how we can help a large number of people. So I want to start by talking about TMS for post-traumatic stress, simply by saying that it works. And there's definitely some microphone feedback. I don't think it's me squeaking. It's probably one of these guys. How's that? That's better. Okay. Okay. These are some very early studies using a lot of different settings of the machines, which I won't go into. Down below is a meta-analysis showing that when you put all of the different studies together, even going back the better part of a decade, that we could see that stimulation was working for post-traumatic stress. So it not only works for post-traumatic stress, it's actually worked for quite some time for this. And again, I spoke about in the last lecture about these different network models of the brain. I'm not going to talk nearly as much about it this time, but I just simply want to remind you of the second half of that slide, which is just as we understand these network models and how the brain is working in depression, we start to understand it more in PTSD. And the more that we understand the brain, the more opportunities that we have to then develop new interventions to help people. So our story, my group's story, really has been in developing this line of inquiry over quite some time. I would say in the early days, we were looking at different kinds of maybe device settings or novel devices and their use for post-traumatic stress, showing again and again and again that these devices were helpful for people. We've also done a number of different studies looking at the brain and seeing how the brain changes when we stimulate it. And I'll show you some of this in a next slide or two. And what we've also been doing is focusing on using some of the new technologies to see how we can get people better, how we can keep them better, and make sure when they do get better, it's not just symptoms, as we were hearing about right before lunch, but it's about getting people back to their lives. So let me walk you through a couple of the key studies that we think about in this space. So this gets to the questions before lunch about how do we start putting these ideas together. So this is a study that was done by a friend of mine. His name is Andy Kozel. What he did was he took about 100 and some odd service members And he gave them 1 hertz TMS, so a slow frequency stimulation, once a week. And it was coupled with cognitive processing therapy. And the way that he did it was he had people sit down in the chair, and literally the moment that they were done getting stimulated, they started talking to their therapist. He did this for about 12 weeks and showed that those people who were in the active group, active stimulation, compared to the sham stimulation group, did really significantly better. These were all recent military veterans. These are folks from many of our more recent American wars. These effect sizes, when we look at the improvement over time, are really quite large. And this is just stimulation once a week, but again, it's stimulation and then immediately into cognitive processing therapy. Another piece I want to talk to you about is one of the studies that I did, where we started looking at these newer kinds of stimulation, the so-called theta burst stimulation. The protocol here was a little bit more complicated, where we were stimulating them actually on the right side with intermittent theta burst, and they got fake stimulation versus real stimulation for 2 weeks. And then after that, we gave everybody real stimulation. And this design was really because we wanted to make sure that everybody got real stimulation. And we had some idea at this point that things were working. We also did a number of MRI scans, which we'll go into in a little bit. Okay, so what did we find? And I'm going to focus. This is a complicated chart, but I've just highlighted a few things I want to say in particular. One of which is that we're able to reduce symptoms. Sure, that's good. But we specifically followed people's ability to function in daily life. And in fact, what we found was that that was something that happened consistently throughout, but it didn't always correspond with the symptom changes. And so we heard a little bit before lunch, yes, it's good to get symptoms down. We want to get people back to their lives. But just because we see one and not the other doesn't mean that we should give up. That in fact, the two work on different speeds, different timescales. And so just because if we see one and not the other doesn't mean to stop. Usually means that things are going to happen later. And then what we did was we followed people for a year later. So, in addition to being a researcher, I'm a clinician. I want to not just get people better, I want to keep them better. And so what we did was we looked at how likely someone was to stay out of mental health care in a serious way. So we looked at over the following year how long it took to relapse. And here we defined relapse as big med changes, needing to come to the hospital, or other very large things. And what we found was that the people in the real stimulation group, and that's in red, that a little bit over 2/3 of them were still okay at a year, as opposed to those people who were in the sham group, which you can see that 60% of them had relapsed in a year. And so what does this tell us? Right? This tells us that even when we're just giving a couple of weeks of stimulation, in this case, this is roughly 4 weeks of stimulation that we gave in the best case scenario, that actually the effects were enduring and we could keep 2/3 of people well an entire year later. So we can do some short-term good and have some really long-term implications for keeping people well. That's statistically significant, and it's essentially people would relapse sort of at twice the speed if they were in the fake TMS group. The other thing I want to say is, and I said this in the last lecture, is that if people did relapse or they got worse, when we retreated them, it still worked. So again, what we've heard now in this study and in other studies time and time again is if you can get people into the chair for stimulation and they can get better, you have a solution for them that will work in the long term. So when things don't go well or their symptoms start to come back, you get them right back in and it will still work. And again, I want to underscore, that allows us to speak in the language of hope for our patients so that we can say, not just are we going to help you now, but if things start to get worse in the future, we're still here and we have something that we can do to help you. So the third study I want to describe as a little bit of a cautionary tale. So this is a study with a different kind of device. It's called a deep TMS system because it stimulates a little bit more broadly and less focally inside the prefrontal cortex. So that's described there. Those yellow and red areas of the brain are where the magnetic energy is going. And if you remember, I showed you a picture of my brain in that last lecture with that little bit of red just kind of over here. So this is a very, very different amount of energy that's going into the brain. So here they took about 120 people and they gave them stimulation. The important part here is immediately before the stimulation, they did some exposure. And in exposure, they had people talk about their trauma and go over parts of their trauma that were really distressing. And what they found was that when you combine the stimulation with that exposure in that particular way, it didn't work. What you're seeing in this slide, there's deep TMS in black and sham in white. What you're seeing is that the people who did not get real stimulation, people who got sham, did better. So what does this show us? This shows us when we have people do a brief exposure therapy, it can be helpful, which we know. But when we directly combine the kind of exposure that we do in prolonged exposure therapy with this stimulation in real time, it's counter-therapeutic. So this is what we do not want to do. So just to some of the questions that we talked about earlier about how do we combine these treatments, right? This is one thing that you don't want to be doing. So there's a few take-home messages from this that I want you to have. When you combine stimulation plus cognitive therapy, stimulation, and then immediately going to therapy, that worked quite well. When you just do stimulation, works quite well. But again, when you put the two together exactly in the same moment, you want to be a little bit careful. Do you want to, yeah, Martha, yeah, Dr. Ernst, yeah.
Can I ask a question? Sorry to interrupt, but on the previous slide, my first question would be, did they include the right group? Because you could then see that study, if you forget about TMS, as just the effect of exposure on PTSD. So with TMS, we always select people with treatment-resistant depression, or in this case, treatment-resistant PTSD. Had they had prior exposure therapy already? I mean, that's the cheapest and best offer there.
Yeah.
Because it's a massive effect.
Yeah.
You saw.
Yeah. So let me reframe what he was. So the question really is: so who are these people, and sort of what it is that we're doing? And I think the really important take-home message, which is what he was emphasizing at the end, was that exposure therapy works really well for PTSD. And if we're thinking about what it is that we want to be doing, this is one of the tools that we absolutely want to be using. And when you start putting the different things together, we have to be ready that sometimes it's not going to go according to plan, and that people can get worse.
I have a question.
Yeah, please.
Could you please explain more precisely what does it mean immediately after and during?
Yeah. So the question is about the timing, right? And so in the first study, they would sit in the chair, they would give some stimulation, they would finish the stimulation, and then they would walk to the next office.
Same day.
Same day, 10 minutes later. In the second example, where people got worse, they're sitting there with the machine on their head, talking about the worst trauma of their lives, and getting stimulated all at the same time. So a very, very important point, and I appreciate the question to make sure that that's clear. It's all really concentrated together. And that as you're thinking about how you might want to use this in your own practice, this starts to give us an idea of the sorts of things that we may or may not want to do. So the next, what I want to do for a little bit is unpack some of the other work that we do in our own military veterans. So we talked about this previously in terms of our National Clinical TMS program. And we came into this expecting and hoping that TMS was going to work. And so a little bit more sort of information about this work, and another picture of one of our devices in our no, that's the same clinic panel as I showed you earlier. We actually used a number of different devices in this study. So we used a couple of different manufacturers, and we really didn't worry too much about it. So there's going to be many different machines and many different clinics. And as we'll see in a couple more slides, many different protocols that were used. So you saw this before, but I think it's important to put it up again. In just focusing on the reduction in PTSD symptoms over time, there's a few things that you can see from this graph. Right? One of which is that there's a curve of getting better here, where there seems to be a little bit more improvement that's happening early, but then it does continue over time. There's one story. The other of which is when you get to the end of treatment, so that number 30, so that number 30 there, just above that number 30 is what we would consider to be remission from post-traumatic stress. So this rating scale score of 33 is our operational definition of someone no longer meeting PTSD criteria from a severity perspective. So what does this show you? This says that on average, after a course of stimulation, as it's just given with a standard machine, we can get people really quite a bit better. And not just about symptom reduction, but really about sort of bringing them close to a remission criteria. And as there were earlier, there's a couple of other questions that are implicit in all of this that I want to walk through with you. Some of these came up in the Q&A earlier. So one question I always get is that depression and post-traumatic stress have a lot of overlapping symptoms. So you heard from this morning that in PTSD, we have disturbances in mood, in cognition, and we of course have that, for example, in depression in terms of our criteria. So maybe this is all just a story about depression. And the nice thing about having these very large sample sizes, so remember this is 700 and some odd individuals, is that we can now start statistically controlling or adjusting for these different elements. And what we can see is they're happening independently. So both are going down, but they're not going down. They're going down independently. They don't depend upon each other for it to happen. So it's not just that people's PTSD is getting better because their mood symptoms of their depression are getting better. What we do see, perhaps not surprisingly and relevant for everything here, is that when you do have people who have the combination of depression and post-traumatic stress together, these people tend to have much higher levels of symptom severity overall. So they're sicker. And that's no surprise to anyone here. But it's important to know that when we're thinking about who's coming into the clinic and what they can expect and what we can expect as clinicians, these are the ones that are sicker and that we need to be paying a little bit more attention to. So there was a question earlier, right, about traumatic brain injury. And so I want to really address that in a bit. I'm going to say mild traumatic brain injury here. This is going to have to do more with our local definition of mild traumatic brain injury. So once people are moderate by this criteria, they're no longer able to really independently like toilet or walk. So our definition of mild is not mild. It's just the thresholds that are being used in this particular study. So I thought that people with traumatic brain injury were not going to respond as well to stimulation. And the reason I thought that is that their brains were injured. And as we saw in the first lecture, right, the energy has to flow through the brain in order for people to get better. And I thought that that was going to be disrupted. So we took, in this cohort, we took about 200 people per group, and we looked at a group of people who had brain injuries, and we looked at people who did not have any brain injuries. And I should say, so these are military veterans, but their brain injuries were not just from the military. They were from all ages. A lot of sports injuries included as well. And many of them had significant and prolonged loss of consciousness after their injury. Many of them had both what's called anterograde and retrograde amnesia. And these are all reflections of fairly significant traumatic brain injury. Again, I think our use of the word mild for how we categorize it sometimes is not great. And so what we found was that stimulation still was helping these individuals. And in fact, the stimulation was really almost just as good in those individuals who had traumatic brain injury as those people who did not. There is, if you squint, a very small difference in change in PTSD symptoms that is statistically significant, but is not clinically meaningful. So the people who had traumatic brain injuries and post-traumatic stress had a 2 to 3 point difference in their rating scales at the end. And that's not something that we would consider to be clinically meaningful. So the take-home message from this is that we should still be doing transcranial magnetic stimulation for people with traumatic brain injury. And this is not a good reason to tell them no. I would say this was good for my patients. It was not so good for my hypothesis and what I was trying to show at the time. But I do think it's really important that whenever we're doing this work, that we come out of it with messages and languages of hope so that we can treat whoever it is coming in the door. Another question that I'm always asked is, there are many different kinds of TMS. There's many different devices. There's many different protocols. When I was here last in November, this is one of the things that we spoke about a lot. And not everybody can buy every device. Some devices are very expensive. Some you just simply can't get. So what do you do? So what I did was looked at Yeah, so this is a different group. These are not the people you saw before. So this is another cohort of about 500 and some odd people. And we put them into 3 different groups. One is who got the standard 10 hertz protocol that has been around for some time. And then we had another group that had the newer intermittent theta burst stimulation. And we had another group that had the deep TMS that we were talking about earlier. And as you look at those 3 lines going down over time, you'll notice that they're absolutely identical. So nothing was better than anything else. Matter of fact, they all worked really well. And we have some other sort of more complicated statistical analysis of this work, very clearly showing that these are all non-inferior to each other, which simply means from a clinical side that we can be confident recommending any of these options. And this is for post-traumatic stress symptom reduction. We also see very similar findings in depression. One thing I want to say is that this was the deep TMS system that caused some problems in that other study when we're combining things exactly. But when it was used by itself, without the exposure, without doing that simultaneously, it still worked pretty well. So it's not a good reason to get rid of that device or to not use it. Just it's a thought about how we're going to combine it or put things like that together with exposure. So the take-home message from this, right, is to use whatever you have because it's going to work. Again, not just here, but everywhere across the world, there are many times where you can't get devices, you can't get certain systems, you can't run certain protocols, but the important thing is to get somebody in the chair. We also work a lot with suicidal patients. This is part of what we do, the more that we ask about it, the more we find it. And so it was really important for me to say, all right, does stimulation also work to reduce thoughts of suicide and related behaviors? So this is 50 of the last people who walked through my door. And we asked, was stimulation helping their suicidal thoughts? The simple answer is yes. And I want to say that the reduction in suicidal thoughts and behaviors was completely independent of their changes in depression. So it's not as if just when their suicidality is getting better, it's necessarily because of their depression. And in fact, and something I want you all to think about as you're going into these next couple of days, we at least traditionally consider suicidal thoughts and behaviors as perhaps a part of depression, part of our various criteria. But there is increasing evidence, biological evidence and other evidence, that these are not the same things. And we always have to be thinking very carefully and thoughtfully about suicidal thoughts and behaviors, because if we don't ask about it, we are certainly not going to find it. So let me walk through a little bit about what it's like in my clinic, and I have some walk you through sort of our day, if you will. We're going to see if this video works. If it doesn't, I will narrate her what she's going to say. It's very quiet. It's not good. You can see her blinking though. That's good. No, we're not. Okay. All right. I'm going to let it play and I'm going to tell you what she's saying. So this is another one of my veterans, and she gave her permission for her video to be shared with you here. And what she's describing was after a course of stimulation for very bad PTSD. She had a combination of all sorts of really different kinds of trauma, all of which were truly terrible. And what she's describing was that after stimulation, she had, in this week she's describing, her dog died. She got into a very large car accident and then got snowed in to her house. And this is someone with a long-standing history of suicidal thoughts and behaviors as well. And what she's describing, you can see on her face, she's like, it just didn't bother me the same way that it used to. And you can see it without the language, right? And this is the face of someone who's describing, who's surprised, right? That something that usually is so terrible just isn't happening. And you can see the relief, or could see the relief in her expression of not having to experience that. Okay. So when I was here last, I spent a lot of time when we were doing the hands-on talking about accelerated TMS. And this is when we're doing a large amount of stimulation in a short period of time. I talked a little bit about, this was a case series that was done during the pandemic by some of my friends, where they gave a brief period of stimulation. So they were giving stimulation 5 times a day for 5 days. So it's a 1-week course with the settings there. This didn't require a functional MRI to figure out where we were going to put it. It was really scalp-based targeting that I was describing earlier. And what they found in a case series of people was that their symptoms got better. So after 5 days, depression, anxiety, and various other symptoms were better. And so that's good. And particularly because we're used to thinking about these things in 6 weeks or so for a standard course of TMS. And so what I did since I've seen you last was I went and I looked at the last 120 people that we gave this treatment to. And what we found was that the symptom improvements were really quite large. They're a little bit bigger, actually, than what we saw in those other graphs of our 770 individuals. So the symptoms are actually a little bit lower when you compare the two. I don't think that's actually going to be the case once we do more people. That was 700 people. This is 100 people. I suspect things will change. What I also want to show you here is that we were able to get people quite a bit better in 1 week, and their PTSD symptoms are quite stable for the 3 months afterwards. And that's also important. You do start to see in the lower graph, that's looking at depression. You do see a little increase in people's depression over time. That's not statistically significant, meaning that it really is very stable over time. But it might mean that once we get to 3 months or so, we need to keep an eye on things. And this is work that we've seen in other spaces with accelerated TMS and depression, that 3 months seems to be a time where we need to start watching. But for your use here, right, this gives you sort of further evidence that you can take a very short period of accelerated TMS. You can take folks with comorbid PTSD and depression, and doing this, you can have a reasonable, you can really help people get better, and you can do it quickly. And like I emphasized earlier, what I do immediately after this is I have people get into therapy. This is hard to do with therapy sort of on the kind of same day model. This is 5 times a day. So people come in usually first thing in the morning. And then we stimulate them for, it's about 10 minutes. And then they have about a 45-minute break. And then they just do that 5 times over the course of the day. If people don't get better, what I do is I generally increase the number of sessions per day, or I have them come back and we do a second week. But again, this is just further evidence that when we start doing higher doses of these accelerated TMS with very simple tools, you can get people a lot better. And again, this just required the machines that you saw earlier, me getting stimulated, and a tape measure, which is really quite remarkable. So what does this look like in the clinic? So the first thing that we do whenever someone comes in is we spend a lot of time on consultation. And what this consultation is making sure that people are safe to get TMS. So it's a lot of talking about the metal in their heads and also about their pharmacology, their medications, about their substance use, and about their suicide. And then what we do for everybody is what you saw earlier, which is the motor threshold, finding out how much energy it takes for their finger to twitch. That calibrates the machine. And then we make a clinical decision. Either people get accelerated TMS, or they get this more standard once daily TMS. And I have to say at this point, now having done, so the last 100 or some odd people, almost everybody likes doing the accelerated TMS because it gets them better faster. And again, as a clinician, it's getting harder and harder for me to recommend waiting to get better for 6 weeks, particularly when things are dire. That said, there are certain situations that makes much more sense to do it once daily versus accelerated. Which I'll get into in the next slide. So our daily TMS workflow, so if you're coming in once a day, this is once a day for 6 weeks, we come in and before we do anything, we get a whole battery of rating scales. We measure PTSD, we measure depression, actually we measure a whole lot of other stuff. And the reason we do that is we want to know where we're starting from. It's incredibly important not just to have a nice picture where you can show numbers going down or getting better, but we also want to be able to identify as we're going if people are not on that track, if there might be something else that we want to be doing. But we don't know that unless we look. So really important before you do anything is we check where we are first. And we do that by measurement with rating scales. Standard of care generally is for once a day for 30 days. That roughly ends up being about 6 weeks. And then what we do is what's called a taper, meaning we do 3 times a week, then 2 times a week, then once, and then done. And the reason we do that is we then inquire with them how it's going when we start taking away the TMS over time. Some people will report that their symptoms start getting a little bit worse, in which case we treat people for a little bit longer. There are certainly people out there that require more than 30 days of regular TMS. The number 30 that we use is really arbitrary. And so that lets us know if they need a little bit more or not. We get rating scales at least once a week. Typically, it's on the 5th day of a treatment series. And so what this means is that as people go through their stimulation, we have their baseline, and we can look at them and how they're doing week by week. And that allows us to then see if someone is not following the curve that we expect that you've seen here. And that's when we have 2 weeks in a row where people are really off of the curve. That makes us pause and ask what's going on. And sometimes we'll do some other protocols at that point. But again, unless you're checking where people are going over time, we don't know where we're going. And I would say for the therapists in the room, this is something else we should be doing. This is not just about brain stimulation, right? This is about all clinical care. You really want to be checking people's symptoms as you go and at a regular interval, because otherwise we just don't know what we're doing. It's very hard to keep track. And remember, all of our patients are having a lot of, these illnesses are all associated with challenges with memory. Remembering how you were feeling from week to week is very hard. And so this gives us a number that we can follow. The other thing I want to say is at the very end of it, I write a note, so a treatment note in our medical record that describes the patient, what we did to the patient, how well it worked, if it didn't work, if there were any side effects, or other things. And that information goes back to someone's primary care doctor, or maybe their other psychiatrist, or whoever their treatment providers are. And so that way everyone can see what everybody else is doing. And again, even if you're not doing brain stimulation, this is a really important practice in making sure that everybody involved in care knows what's going on. The accelerated TMS workflow is a little bit different. I actually, so we start with a motor threshold, as usual. I actually check rating scales, check people's symptoms on the morning of every day. I don't do it at the end of the day because people are usually very tired after we've been stimulating them for 6 to 8 hours at a time. So they're exhausted and thank you very much, they just want to go home. And so they go home, they get a chance to sleep, and then in the morning we ask them to reappraise how they're feeling. And so that gives us a day-by-day rating of how folks are doing. As I mentioned, the treatments generally are 5 times per day with roughly a half hour to 45 minutes in between the two. For the physicians and trainees in the room, every time we deliver stimulation to their brain, we write a separate note in the medical record. So we want to be absolutely sure that we're tracking what's going on, and so we can see how much we've given and what's going on as we do it. Every time we put a magnet on someone's head, we have a note and we're tracking it. I mentioned, right, the symptom rating scales, and then after the last day. And I want to say that the only time that it starts getting more complicated doing accelerated TMS is, I want to say, caution around the motor threshold. And remember, as I spoke in the last lecture, there are a lot of things that change the motor threshold. And if someone, for example, is struggling with alcohol, and they come in the morning and maybe they still have a little alcohol on board, and then they start withdrawing over the course of the day, their motor threshold in the morning and their motor threshold in the afternoon are not the same. This is particularly important for amphetamine users. So people who are struggling with cocaine or meth or other things that we have that come out of the body very quickly. This was to the question that we got earlier about using sort of some of these amphetamines to augment effects. You gotta be very, very careful about these because if someone's motor threshold is different over the course of the day, either we start stimulating too much, which is dangerous and it can cause a seizure, or we are stimulating not enough and it's not gonna work. So in situations where patients might have an unstable motor threshold, I do not do accelerated TMS. I'll also say if I have a high clinical suspicion that they're using substances and are not telling me about it, I also do not do accelerated TMS. I will do once daily TMS, but I want to be very careful about that. And as usual, and then a nice big note at the end in terms of what it is that I've been doing. So some concluding thoughts, and I'm going to bring in a few things that I think are going to be specifically relevant to here. What's really important, right, is that at least what we've seen so far is we have not seen that any one particular device or any one particular protocol is better than anything else, at least on the level of the population. I suspect that each person is a little bit different and the story there is not so simple, but for when we're thinking about what it is that we're able to do, not having a particular device or not being able to do a particular protocol shouldn't be a reason to say that we're not going to do stimulation. So really you get to choose based on logistics and on safety. I do want to make a comment, a few things that I've seen in my veterans here, which I think are relevant to you. And so we have seen some, I've written this up a few times, we have seen some evidence of prevention of re-traumatization. Now, these are people who have been through, who have PTSD, that's the right reason they're seeing me. But we have seen that when these individuals have been stimulated or are being stimulated, that we can prevent the PTSD from coming back or for them generating a new kind of PTSD. And I think here in particular, as it's used here, this is going to be an opportunity to see if it can be used in some sort of prevention. Remember, what we're doing is we're stimulating that prefrontal cortex, right? We're stimulating that part of the brain that helps regulate everything else. So maybe, just maybe, it's a way that we can prevent things from certainly getting worse. And a little comment there, sure. The other thing, which I talked a little bit about last time, but I didn't come with a lot of details, is some of the work that we've been doing increasing access to transcranial magnetic stimulation outside of the clinic. So the machines work, we can get people better, but what we need to do is we need to get the machines to the people. And we've not been able to do that before. They've been too large, they've required too much energy, they've been unwieldy, whatever. But as you saw, right, as you saw from the device here, and even in one of the other ones that Dr. Arns has brought here with us, this is really not, it's not as much of a problem as it used to be. We can start thinking much more creatively, right? So we now have machines that can travel. We have protocols that can get people better in a week. And so now we have a compelling story to take this and move it out of the clinics and to go where it needs to go. So one example that we're doing right now is in the state of Montana. It's a very large state. And it's very hard for anyone to get to care. And so what we did was we took a RV unit. These are very popular in the States, by the way. And we just hollowed out the inside. And we put a TMS chair in there. And I want to walk you through a few things that you can see in this picture. So there's a chair and there's lots of screens. So what I'm circling here are a series of cameras. So there is no doctor in this van. The doctor is looking through a video screen from 1,000 miles away. So this is done by a technician or a nurse. And what this van does is it drives from town to town. It typically stays a place for a week, because what I showed you was that 1 week protocol that could get people better. It does as many people as it possibly can, and then just drives to the next place that it's needed. And so what does this require? It requires a device that can move, it requires a camera, and it requires a single technician, maybe two, to go out with the person and make sure that they're safe and be able to manage it if, God forbid, they have a seizure or something like that. You know, we're talking about a single isolated seizure that's relatively low risk. We're not talking about something more serious. And so these are generally monitored by emergency medical technicians, not by physicians. So what we have here, right, is something that can really move. When I spoke with many of you last time here about how this can be rolled out really directly. And what I hope that we have done is created a model here that you can use and put TMS wherever it needs to go. And like you can see in this picture, right, it's got wheels, right? It's not stuck somewhere. So, and it's to let it go where it needs to go. And we have a central person, you know, we have 2 or 3 physicians that are just monitoring things remotely via video from a central hospital. And you could implement that tomorrow. Oops. And I think, so I skipped the Bitmoji pictures. So there's some pictures from last time I was visiting, so my apologies, Ola. But I do want to say thank you for having me. It's delighted to be here. And there's my wife and kiddos up above who also send you all of our best. So thank you very much, and happy to answer questions.
Thank you very much. And you can see this is a Ukrainian version of TMS machine. Це не жарт. Це справді одна з універсальних способів компенсації лікування посткомоційного синдрому. І ми це бачили. 2, 3, 5 занять, і нейропластичність мозку змінюється. Це звичайний ткацький верстат. Звичайно, багато зусиль, багато вчитись бути ткалею або ткачем, треба ще вчити психологію, але це дуже серйозна річ. Але ми можемо її доповнити транскраніальною магнітною стимуляцією і зробити дослідження ткацтво і ТМС. Так що дякую ще раз вам дуже за надію, сподівання. Ми справді будемо разом працювати далі для того, щоб впроваджувати це. Ми зараз навіть вже ведемо перемовини з нашою військовою академією медичною про те, що вона може власне стати ініціатором в державі створення мобільних груп, які будуть виїжджати в зону бойових дій і лікувати пацієнтів, які мають посттравматичний стресовий розлад. Чи ви робили дослідження щодо ТМСу і гострого стресового розладу? Not acute reaction,
Acute stress disorder. We have to some degree. The simple answer is it still is helpful. The more complicated answer is that I don't know how many of that was not a situation where I could control everything that was happening. And as we saw earlier this morning, a large number of people do get better spontaneously. So I don't want to be overly, but I think, but importantly, right, if we're thinking about treating things acutely, this is something that is safe and is easy to do, as opposed to if you were going to give a medication acutely where you might worry about it doing some harm. And some of the medications in an acute stress situation can make trauma worse and make PTSD worse. And that's not a concern that we have here.
Дуже дякую. Справді до нас дуже часто звертаються керівники медичних служб бригад, і вони просять допомоги, і ми насправді в такий спосіб можемо наблизити цю допомогу, неінвазивну допомогу ближче до фронту. І коли я слухав зараз я думав про пробацію. Люди, які потрапляють на пробацію, це насправді люди, які мають глибоку і хронічну депресію в тій чи іншій формі. І кожна з ваших центрів в країні, маючи такий інструмент, де не треба лікаря, може серйозно і ефективно працювати з такими людьми, зменшуючи напругу, депресію і безпеку, найголовніше, що для них, то і для вас. Тому, я думаю, також Міністерство юстиції після вашої презентації може подумати про це. Я бачу в цьому величезну перспективу.
Я теж бачу. Будемо в цьому напрямку рухатися і сподіваюся, що ми досягнемо успіху, а перш за все допоможемо людям, звичайним людям, які не лише на пробації, а...
Мусите повторити ще раз. Переклад не працює.
Я зрозуміла. Повністю погоджуюся з вами, тому що я думаю, коли ми будемо з вами разом в цьому напрямку працювати, і Мін'юст почує нас, і таким чином ми зможемо допомогти не лише засудженим, а й всім особам, які страждають на депресію, на ПТСР, і, зокрема, військовим, тому що це важлива категорія в наш час, в час війни. Дуже дякую. Я буду все робити з моєї сторони.
Дякую вам. Ми не тільки допоможемо засудженим, але й нам. Окей. Я пропоную всі запитання перенести на кінець, так? Якщо немає таких запитань, що ви не можете їх не задати вже, бо забудете потім. Окей? Тоді переходимо до неймовірно цікавої інтервенції, яка, на мій погляд, є панацеєю. Може, конкуренція зараз з ТСМом. А це є пролонгована експозиційна терапія. І навіть в тих дослідженнях, які ви бачили, насправді між транскраніальною магнітною стимуляцією і пролонгованою експозиційною терапією є конкуренція. В деяких випадках терапія переважає над. І нам дуже важливий стосунок. Нам дуже важливий стосунок людина з людиною, бо травма ізолює. І транскраніальна стимуляція може допомагати, але також може і ізолювати. Тому, професоре Ілан, але перед тим, як ми почнемо лекцію Ілана, дуже коротка 5-хвилинна перерва на каву. Будь ласка, можете випити каву. 5 хвилин? 5. It's going to be that 10.
In Ukrainian time.
But the quality of that particular rating scale for the repeated subjects measure. I said, I think I even expressed that. No, it's not a type. No, it's not a type. Yeah. But
The second thing then, 2 slides later, it went on to survival. Your label was a sham, and the other one wasn't a sham. So it was more to say that more sessions gives more to go.
so we had the other thing that we had in there. These people, I think, were just the sham. I think they were just the sham. I don't think they were. The best part of that paper, though, that was never. But I think the days of us doing something.
Straight from, I don't buy that those were hard to treat or I think that any PTSD patient because you see such a massive
there was a few of these other studies where was it the early brain? It was some early brain where they had some negative. Yeah, maybe we can do it. But Andy was very good. I remember when Andy was doing that study.
Yeah, true. But I think, I mean, to some degree, you can get away with
Yeah. Yeah, I still feel like some part of me though, some part of me always wants to see some RCT data. That'll make I would feel a little better. But that's a 100. Those were 15, 16 different
Що ж, панове, наближається до кінця і дуже швидко наш перший день школи, 7-ї школи, яка вивчає травми війни. І зараз Ілан поділиться своїм досвідом важливої терапії, пролонгової експозиційної терапії. Скажу вам, що це найефективніша річ поки що, яку я бачу з тих інструментів, які ми використовуємо в нашому центрі ментального здоров'я. Єдина проблема цієї терапії – це важка емоційна терапія, як і для пацієнтів, так і для терапевтів. Тому треба добре знати себе, добре розуміти свої власні травми, мати добрий стосунок і рапорт, альянс з пацієнтом, довіру. І це потребує професійності. Тому сьогодні послухаємо це від Ілана. Дякую, Ілан.
Thank you. So I will try to give kind of an overview. We cannot teach a psychotherapy in an hour and a half. And we have to remember there's no treatment that works for everyone. So that's something very important to know. And I think we talked about it, and I'm so happy, when you see that TMS is working, and you know that a lot of people don't want to talk, not in this space that they are ready to talk about stuff. So maybe doing as Noah noted, do TMS. You're starting someone, they engage. It's not as stigmatizing. It's a device, and it seems to reduce symptoms very significantly. Again, this is a talk therapy, and I think it's very intense, and it's take a toll both on the therapist, and one of the issue is that we many ourselves avoid sometimes because it's so overwhelming, so we just don't want to go there. But for this psychotherapy to work, you really need to engage in the processing of the trauma memory. So again, we talk about PTSD, and I'm not going to go over it again. The re-experiencing, the avoidance, the depression, hyperarousal, and ICD, again, without the depressive symptoms cluster in it. What is really, and I will talk it in more detail, is that, prolonged exposure really works very well in addressing this re-experiencing. You're working on the trauma memory, but also on the hyperarousal, because it's really tackling the avoidance of places and the thoughts of feeling about the trauma that allow the patient to move forward. So if you think about emotional cue reactivity, physiological reactivity, are very cue to the hypervigilance. Those are overgeneralization of fear. Anything that's related to the trauma will activate those systems that quite may be a same biological system. And you have the intrusion. So this is overgeneralization of fear. And this, you have to remember, we're talking about memory reconsolidation processes. That the memory is not processed, is fragmented, and wanted to get some coherent aspect of it. That because we're giving the same, I'm giving talks the same day, this is also the notion that the most effective treatment currently in all the meta-analysis is the indication that trauma-focused psychotherapy gives you the most robust improvement in treatment above and beyond medication. and this is why to do it. So exposure therapy was not born today. And if you, I know that a lot of therapists, psychiatrists here in Ukraine in the previous year were like really psychodynamic, psychoanalytic trained. So I joked with Ole, it's like psychoanalysis on steroid. You know, you're really accelerating, you know, processes that will take years in psychoanalysis. So you're bringing a lot of things that you wait in psychoanalytic to come by themselves and then discuss it with the patient. Here, you don't have it. You just say, let's go deal with it. And here, Charcot in 1800 something, I don't remember, 1877, already talk about the hysteria. I remember people suddenly could not move the hand, or they got some symptoms that they get paralysis. And they realized that that was caused by people not processing traumatic events and inability to integrate traumatic memory into autobiographical memory resulted in some physiological manifestation at the time. So the kind of really like going through the discussion of the trauma resolved some, you know, physiological symptoms that were trauma related. They were kind of moving the symptoms away from the trauma to some physiological reactivity. The same is of also Freud and Charcot, that both really influenced by Jeanette's work, really talk about the traumatic events causes alternation in consciousness, okay, which leads to a inhibition of reactions and really paralysis of thoughts, emotion, and action, okay? And the idea is that emotion activation and reliving those suppressed denial, all those emotions that you're not letting yourself experience is causing the symptoms. So about dealing with those raw emotion, very painful emotion, will create catharsis that let the patient move forward and understand a lot of their symptoms and then move forward. So many years before Edna Foa that wrote the manual, there was already an entire group of psychotherapists that did exposure therapy, but in a different way that took years and time. Now we're going to talk about how we can accelerate it. It's kind of doing it in a more tough. So again, issue with psychoanalysis, it takes time, takes 5 years. Sometimes if you are in a good psychoanalytic, you know, and it's really hard to do the treatment when you have so many soldiers. You're not going to go into psychoanalysis. Even short-term psychodynamic treatment take about 1 year to 2 years. So that created capacity, you know. If you want to deal with soldiers, that this is their work and livelihood, and in a way you can treat them, and this is from military perspective, and I know it's a lot of issue for therapists. If I'm going to make him better or her better, they're going to be sent back to the front line. So that's another issue. So I know that you're struggling, but regardless of that, we want to make people better as faster as we can. Another issue, of course, there's not enough psychoanalytic research. No? Many psychoanalytic people don't do research. They do it, so it's hard to build a good body of evidence of the effectiveness of psychoanalysis within this realm of PTSD treatment. And we talked about the monotherapy. If you're just giving medication by itself, it's not good enough. So one of the principles that I talked earlier is the memory reconsolidation, okay? And the ability of human to change the memory that we all storage our brain. I don't know if it can also lead to false memory. We know that there is a lot of research that show that therapists or if even like crime investigation, you're putting suggestion, you're changing the person memory. So if you say, oh, there was a car accident, you say, do you remember, the red car that came, there was no red car, but they just mention it. So you have to be very careful here, because also we can influence, because the memory become liable and unstable. It can create also false memory with the therapy. So it's a very, very thin line that you're going. But if you work with the patient slowly to rebuild and create the story of the trauma, okay, the memory when you recall them is amendable to change. You can help the patient create a story that will be stable and can be carried over with their life. It's like part of yourself. So you're kind of trying to create a new sense of self after the trauma. You're never going to be the same. And the expectation that you will be the same should always be discussed, because if you're going to lose a leg, you're not expected to see a new leg. You might get a prosthesis. So same if you have a sustained an injury to your mind already gone through a trauma. It's not going to be the same as it was before the trauma. It's going to be amended and hopefully cured to some extent, but it's not going to be the same prior to the trauma, because you have new experience that you integrate. We change, we grow, and that's part of who we are as human beings. So as I mentioned, in post-traumatic stress disorder, the memory of the trauma seems to be stuck in its original form, like it gets stuck in the moments of the trauma. It doesn't get updated, where I talked about event, if something happened to you, you talk to friends, you talk to family, you process it, and it's become tolerable. Because they avoided so much, it gets stuck in its original form and really, really doesn't let go. And this is the memory reconsolidation. Remember, there is the other things that we talk about is the overgeneralization of fear. That things in the environment really remind the trauma, and they also create the fear system. So we can help the patients to move forward in this kind of therapy. What I like in specifically prolonged exposure is it's very parsimonious. It's very simple. 2 ingredients. It's like you're going to make the best cake in the world that has only 2 ingredients. You don't have to cook. I know that some people struggle with cognitive behavioral therapy or cognitive processing therapy. There is a lot of elements that one goes through. Here you have 2 components. In vivo exposure, okay? In vivo exposure and imaginal exposure. The in vivo exposure is when you are sending the patient to confront their own fears about things that are safe but perceived as unsafe. And the imaginal exposure is those processes then you're working to reintegrate the traumatic memory into the self. Okay? The therapy itself, by the protocol, is between 9 to 12 sessions. People get better pretty quickly. After like 6 sessions, you see dramatic increase in symptoms. The homework is not writing. It's about doing stuff out there. To go to a restaurant, go to a crowded place. We'll talk about it. Okay? And we also record the session. So patient can listen to the trauma again and again in order to help them to integrate it. So that's part of the homework that they take away. So how you start the treatment? This is kind of an overwhelm. I think it's, I'm pretty sure, Ole, do you have the manual translated to Ukrainian? Yeah, so I'm just give you some extract from the manual, but you start with educating the patient, okay, about what is PTSD, and how traumatic memory affect their life, okay? And comorbidity and other psychiatric disorder really are not interfering much with prolonged exposure. There was some notion that if you are actively using substances, you might not benefit as much. Of course, if you're intoxicated every day to a level that you need to go to detox, it might not be a good treatment. But if you're actively using cannabis, alcohol to a certain degree that is alarming but still manageable, people still can respond. And it's also like we have a study that showed that opiates user actually reduce opiate use if you don't wait them to get off of the opiates. You do it together. So it's kind of not necessarily that you're not going to do it if someone is using. It's kind of a clinical judgment by the therapist if patient can be attentive enough, engage in the treatment, but there's no risk that someone will go to emergency room because they're going to re-experience it so badly. There is no much adverse events that occur with the psychotherapy. Okay? Very important, as Ole talked about, is the alliance. The need for the patient to trust you that you can carry the load of the trauma, because it can be very heavy. People did horrible things sometimes in war, and they very feel ashamed, and there will be a lot of, tomorrow we're going to talk about moral injuries, to things that you've done, and then ability to someone to tell you those stories really depends on the ability to trust you, that you'll be non-judgmental, that you can take it. And some people really feel that if they're going to expose you to what they have gone through, they're going to traumatize you. So you also want to make them sure that they know that you are there and you're capable and to carry that load that they put on you. And it's tricky because I mentioned in the past, I did sometimes, because the story was so difficult, that I feel suddenly like I had a tear in my eyes. And I said, patient, it's okay, your story is very sad, but I'm okay, don't worry, let's go. But again, we are human beings, but sometimes you hear horrible stories, and it's hard to stay neutral. In psychoanalysis, you need to have this hovering attention and stay non-judgmental and say, But here it's just, the stories are so overwhelming that sometimes you're going to have some reaction, but as long as you feel that, the patient don't feel that they are creating an injury in you, then they can trust you and they can feel the empathy coming across. So what we do usually in our clinic, and it's a little bit beyond the protocol, if you're going to read, we're doing a very comprehensive intake. And we're going through the entire developmental history, because it's not just about the war. It's about how people make sense of the trauma in their life. So I will give you an example, because there was someone that really killed a civilian person in the context of war in Iraq. But why someone will come to do that, and it's really like how you make sense of that. So without learning about their history and understanding the defense mechanism, so I don't know, some of you being trained in CBT, but it's really important to get the notion that our psychic is driven by manipulation to stop us from feeling certain things. It's kind of protective, and so to the patient themselves. So if you go through psychodynamic treatment and psychodynamic case formulation, you learn to identify those. A very prominent will be like repression, regression, intellectualization. There is a list of here of defense mechanism, but this person like growing up in a house that was like, I'll give you an example. There was really nobody talk about emotion. Emotion or not talking about. And there was kind of even abuse by the father toward the mother, okay? But not toward the person themselves. But there was kind of seeing it, but nobody talked about it. And they can go and sit in front of the television and nobody will say something happened. So kind of denial of all the emotion in life of pain was really like a way that this person grew up in. And this person lost a lot of friends during the war. They died in a very tragic, but they never process it, never let themselves think about it. And also really develop across this course of the war, the denial of fear, that they just pretended that it's not dangerous anymore. They just went through like robots. They never let themselves feel fear because they say, if I will feel fear, then I will be dysfunctional. But you need to feel fear. Fear is a survival. You need to have some level. You don't want to be afraid of all the time. So when they had encounter with a civilian, when the civilian like was standing like that, and then they move away and turn toward them, they got suddenly like a flash of fear that was so uncontrollable that they just killed this civilian. And but the interesting thing that they couldn't talk about this event. So they sat in a room, I will talk about the technique in a minute, and they were just quiet with me. They say, oh, I saw this person, we approached them, and then they were quiet. And I let it stay with quiet for a while, for 1 minute, 2 minutes, and then they say, oh, and then I killed them. And then after like 2-3 sessions, I realized that, wow, this being quiet, it's really transference, if you know the notion of transference. It was like being together at home, like they were sitting with their mother, and the mother was like beating, like got really beaten by the father, but didn't say anything to the patient. So suddenly I say, oh, sitting here with me, it's like you sitting with your mother, and something horrible happened, and nobody said anything. And then she started to cry and say, oh, shit, I just killed an innocent person. I just killed it. And then realizing that what happened, they were overwhelmed by this tremendous amount of fear that they repressed. And that's not just fear. It was also repression of anger, because they were so angry toward the enemy all the time, but they never processed it because they saw so many other of their friends killed by the enemy, and some of them in a very brutal manner, that it really took a toll of them. So this catharsis is able to understand why they act. They realize that they're not psycho-killer. Okay? So kind of putting in a context, why is understanding the relationship? And it makes a material when you build a whole, so this, I cannot underemphasize how much the formulation, understanding of the patient is important before you start exposure therapy. Because the pure manuals say, you know, take a trauma history and start the treatment. But when you talk to a patient and say, oh, this is horrible, this is so bad, it's not enough. The extra information that makes sense of why things happen, or some things doesn't have really a clear explanation, but you can put it in a course of how the mind process that trauma is so important for them. So taking those people that have psychodynamic, psychoanalytic background and bring this knowledge into the exposure therapy, it's extremely important notion. And if you are not like a psychodynamic in training, it's good to have supervision with a psychodynamic, psychoanalytic supervisor, because it's adding another layer to that work that you're going to do with this patient. So learn about them, how their object relationship as growing up, how they, how they gone through other relationship before, because not all the problems started in the military. We know that some people before this war, it's a professional army in the Ukraine, and some people decide to go from the army for particular reasons, because they want to go away from poverty, they want to save money. I don't know what the reason, like people went to a professional army in Ukraine before the war, before you were taken to that. And I know that also there is difference between people that are in a professional army and people that came afterward. They have different things and different perspective of the service. So you have to really take those time with the patient, a lot of time before you starting the exposure therapy to understand them. And how it's effective if they suddenly were stopped in the street and say, hey, you have to go to the military because we need soldiers. What did they think about it? What they make up of it? It's really important to build understanding of the human person before you're going to just ask them to tell you about what happened to them in the war. As I mentioned, one of the major things that really keep this trauma going is the avoidance, okay? So you avoid things, you're not going places, you just don't want to do anything that will remind you of the trauma. And every time that things come to your head, you just push them away, okay? So you just keep them away, and that's what really good in exposure therapy, it doesn't let you avoid anymore. You have to go out, and you have to deal with your feelings and the thoughts related to that. And it's very intense. And another thing is, of course, all those thoughts that you have about yourself. Why did I do that? All those thoughts are going, like, you remember the cognition that runs through your head. There's not much difference, in psychoanalysis and cognitive. It's that I think there was a conversation between Beck, that was a psychoanalyst that invented the cognitive behavior therapy, and Bowlby, a prominent British psychoanalytic, how you say? Psychoanalytic. So Bowlby really created what is called the internal working models, the way that people create internal working model about the words and others, depending on the way that they were raised by the parents and their primarily caretaker. Beck said, no, I don't care what happened. Just let me know what you're thinking, and I will help you to change just thinking. Let's say if it's rational or irrational, let's examine it. But in essence, both of them are trying to change the way that we think about ourselves and the world. Throughout this work, I think when you have some background, where Bowlby's thinking is, okay, let me know and understand how your relationship were. I will help you to change those maladaptive cognition in a better way. And we are meaning-making machines. So as more we have information, it's help us to make meaning of things. If I know that I act in a certain way because of this, it helped me to change this behavior better. So that's why it's so important to build. So, as I mentioned, prolonged exposure, PE has two components, and the session one that I talked about, it, you can take session one to take more than one session. You take it as much as you need it. You can use 3 sessions, 4, just that you know the patient and understand them well enough. If you have the time, again, if you have to do accelerated, and I talk at the end about accelerated, moving things faster, similar to what Dr. Philip showed, moving extremely fast, then you have to do things a little bit differently. But here, what we do in sessions 2 is building a hierarchy of things that people avoid, that you want them to go out and deal with it. Okay, that's construction. Okay, I'm not going to go into detail because this is like for a more whole day workshop, but the idea is to, and we can give you a copy of the slides, okay? But you're just trying to build kind of a common reaction to PTSD and why you avoid, we talk about overgeneralization of fear. So I will go directly to the mechanism. Again, this is to tackle the overgeneralization of fear and stop you avoiding, okay? And how we do it? Systematic exposure. We send a patient every day out to do something. And it's like also kind of what is called behavioral activation. You force them to do something that otherwise they will not do. And if you can know, even when you're treating depression, even if you're psychodynamic, sometimes it's good to say, you know, maybe you put in your schedule 1 hour, take a walk next to the river or be in nature, because that has a meaning. You move out of this static position. It's very important to do that. So before you go and send them out, what you do is create what is called subjective unit of distress. It's a measure that helps you to see how patients avoid things. And there is scores going to 0. You have no anxiety. For me, let's say being on the beach, sitting down, looking at and listening to the waves. So you ask the patient, what is 0 for them? And you put it to 0, no anxiety at all. You say 100 is the trauma, where you felt your body reaction, how you felt when things bad happen. Let me do it here. It's his translation. Say, and for me, let's say 50 is like giving a talk in front of a lot of patients. I get people, and I get very anxious, but I do it. I hate, but I can do it. So 50 will be something that you reach. You know, it's okay. It's maybe unpleasant, but you can do it. So you ask the patient what it is, and they'll tell you what is 50. And let's say, I don't think 25 is needed because we won't take the list. I will show you later how to create a list. And then you say, okay, what is 75? I'll say for me, let's say a police officer, you know, you're driving on a, and then suddenly police will stop you over. And I'll say, okay, this is a very anxiety provoking. Let's say I don't want to be in this situation. Of course, I want to avoid it as much as I can. So you created anchors. This is kind of subjective unit that the patient can use as reference when you ask them the next questions. So then, after you created this list of 0, 50, 75, and 100, you sit with the patient and you ask them, okay, just give me a list of all the things that you avoid, that you don't do since you were, exposed to the trauma. And they started to produce a list of things. I think there is common. This is kind of people that were sexually assaulted. This is for the military. It's, being around unfamiliar people, okay, that looks and remind them people. They driving in like very heavy traffic, being stuck in heavy traffic. They will give you a list of things they go, like going to a concert or going to a crowded places. A lot of people don't like to sit with the back to the entrance because they're afraid to be surprised, talking about the war. They will give you a list. Okay, let's say they will give you a list of 10 things that they avoid. Even if they give you 2, it's fine. But you need to get a list of things that they avoid. And this is we're still in the very easy part of the psychotherapy, but it's very technical, but it's very like one session, you finish it. I'm just giving you the background. You create a list of things that they avoid. And then you just put them on a paper, and you remember you already created the anchor, like the 0, 50, and 175. I don't know why. and then you just give it numbers. You say, okay, going to in a public places, they will say 75. Driving in a rush hour is 80. Talking about the trauma is 90. Okay? So you tell them, okay, you take those three tops, 90, what I mentioned, driving, talking about the trauma, and then they have homework. You need to do it. You need to spend 20 minutes a day doing exposure to those things. You need to go out to a public space, go to to a very crowded shopping mall, and stay there for 20 minutes. You're going to feel that you want to go away. I cannot promise there will not be like a robbery there, but most likely not. You need to stay with the anxiety and the fear and let yourself know that it's a safe place. And create this inhibition that you are in a different context. You're not going like in a war zone now. Those people are not dangerous. You have to let the inhibition process kick in. You need to start to initiate talks to your friends about the war and start to talk about it and see that you're not falling apart. So those things must and need to be done consistently. The problem with the overgeneralization of fear, let's say if I think this lecture room is dangerous to me, and I will come to the door and then walk away, my brain will think, oh, why did I turn away? Because this place is dangerous. So it's reinforcing the danger. So if you're stopping doing exposure, there is the reinstatement of fear very quickly. So you need to be really consistent of exposing yourself and staying with this unrealistic thought that this situation is danger for you. You have to teach that it's not dangerous anymore. So, if you go and the patient will have like kind of a small page that can see, okay, today I went to the shopping center. Before going ahead like 80, it felt very bad. And then when I left there, it was 75. And when I was inside, it was 85. So the peak, the highest. So they need to rank it. And over time, if you do it consistently, you will see that the patient will start to report reduced level of distress. But they have to be consistent and do it every day. So they do like you choose the 3, but when it's hit 50, you can say, okay, I think it's okay. You know that it's unpleasant, but you can do that. So they know that they can do that. This is only dealing right now with the overgeneralization of fear, as we mentioned about avoiding, trash can and all those things. In prolonged exposure, the most important thing is working on the traumatic memory itself and processing. And this is the heavy lifting. So from session 3 and onward, most of the session is about processing the trauma memory, what happened. So you spend the next 5 minutes, you ask them, how was your week? Did you go out? You're just making sure, but it's 5 minutes. You just do a checkup on this in vivo exposure. And they show, yeah, I went and it was okay or it was horrible. Say, don't worry, just continue to do it. It's not taking the session anymore. It's something that you check and just encourage the patient to continue to do the in vivo. But now, from session 3, you're starting to process the trauma memory. And you ask the patient, actually, to close their eyes and talk in a present tense and take you through the trauma memory. And you ask them to try to remember as many details as they can, okay? Including emotions, experiences, smells, just to take you, and it's like moving. I usually think about taking me like in a slow motion movie through this experience that you went through. And then the patient will start and recall the trauma memory. And you need to do it several times for the hour. So it might be like 5-minute story. So they will have to do it like, 4, 5, sometimes more. And it's, so they finish and you say, thank you. I know it's very hard, but please, can you go over it again? So that's the first session 3. I would not interfere with the patient. I will just be sympathetic, because I think they are just testing you, they're testing the ground, the safety. And what will be like very interesting is that every time they will recall the memory again, they will start to remember more elements of it. It slowly will grow over time. So I know I talk about processing, but I would not start to do processing at session 3. It's the first session. Just, I would say, I know it's very hard. I really appreciate it, but it's really, really important. As I mentioned, in the education, you have to tell the patient why you're doing it, because you want to help them to create a story that they can tolerate. It's going to be a very sad story. It's not going to be a happy story, not a neutral story, but a story that they can live with. And when they're going to experience it, they can think, oh, shit. That was really, really bad, but I'm okay. And take a deep breath and move the day and not get into this whole flashback. They cannot really see small element of it. They will have a whole story that they can tell themselves and live with it. And it's very hard. So in this first session, I will just stay with them and let them talk about it and let the memory be reactivated. So the idea is to enhance the patient ability to access all the salient aspects of the trauma memory about the event, thought, emotion, any sensory experiences, and to really be emotionally engaged with the trauma and create a self-narrative about the memory. And when you go with this treatment over time, there was a question when you start. So if someone had a multiple trauma, someone go to war, on day 7, their friend X, lost 2 legs. 5 days after, a good friend died. A month later, there was an explosion that killed 7 people. What you gonna choose? Some people come with single trauma, but you have multiple traumas. So this is really, really important to know that trauma in the brain are interconnected, because the way that they are being coded. Because why we have re-experience and overgeneralization of fear, because there is the context that are really like connected. So you don't have to go over all the memories. And here I gave a story because I had a police officer that responded in a year to about, I don't remember, 6, I think, suicide. And this is very hard. And so he chose to talk about an event that he went to a young 22 years old person that hanged himself. But he was responding to that several times. But you remember the last time that he had to send, oh, this guy is dead today. But he had other memories of, he talked about one trauma that he went to a high school, and on the swing, there was a teenager girl that hanged herself on a swing. And he had another experience that he went to a house that father overdosed on medication, tried to kill himself with medication. And he was resuscitating this father and vomiting, and the child was screaming next, that the son was screaming, So you realize when you go and do imaginal exposure, I'm not going to do all those stories. And he really, for him, it was this notion that when he went to this story about responding to this guy that hanged himself in the shower. When he came to the house and he was walking and going up the stairs to the apartment, of course, in his mind, he thought, okay, this guy gonna be dead today because I was here like 2 times already. He tried to kill himself, but I have a bad sense. But when he was walking up the stairs, his memory also fire up this memory of the girls swinging. It was horrible. You can't forget it when you're going and responding. That was like really tremendous. And this guy that the father is doing recitating and his son, screaming in panic, all those memory comes together. He was not walking down the stairs. So we just brought when we process it, we just say, you remember when you went up the stairs? How the images of the girl and the father and all those things that you have done already came together. Help him to understand, and the processing, like how heroic someone and how strong someone can be emotionally to go up the stairs and not just turn around and go. And those soldiers are in a situation that everybody will run away otherwise. Okay? So you don't have to choose one memory because all those trauma memories are related and you can integrate it in the therapy, but it's really required a lot of supervision and talking to your supervisor or peers to understand and how to do a well integration of when you have multiple trauma. If you have one, you deal with that one. But if you multi, it's really important to create a narrative that integrate those many, many traumas together and try to make sense of it. So it's very, very intense treatment. And I know that, our therapist really needs a lot of help because, it brings so much trauma and also create a lot of distress in the therapy. So having also some, way to share it with other people, have your own therapist, have very important to have a hobby, things to do outside work, to, meditate, swim, run, I remember one of the psychiatry residents was in acting group and, do other things. You need to really get out of this trauma world because it's really, specifically, it's very toxic. But again, you don't have to go over all of them. You can choose one of them that in some way can represent and hold all the elements of all other trauma if you have multiple trauma. The most critical thing is the processing that comes together and how you make sense of it. And not everything makes sense, That's a problem. That's the reason that you need to build a really good case formulation in the beginning to help you to process this amount of trauma. And as we mentioned, because when you're talking about the trauma, you bring in the memory into label state. Now you are, you are the magician as a therapist. You have this material, the dough of life in your hand, and how you help the patient create something out of it, or sculpture, maybe it's a clay, maybe it's better. And the clay is soft right now, it's not hard. You need now to create this sculpture of life for this patient that it will be hardened again and become a memory. It's something that they will look into and can live with this sculpture. So again, we know that unstable memory really needs you to help them. And this is kind of the processing they go through that. And again, a patient that, I'll give you an example, again, it's a high-ranking officer that in the military that really was, arrested 2 Iraqis, and he was like really interrogating them with his interpreter, and then, he just lost it and took his gun and just shot them blank in the head because he just couldn't take it anymore. So is he like a serial murderer? Is a psycho killer? how someone like that makes it, without understanding, again, the history, how you help person become with all this guilt, overcoming this, what they have done, without understanding like the way that he grew up, again, and how he processed all this military. When you're getting high rank in the military, you have what is called illusion of control. You think that because you are high rank and you have this, ability and you have a weapon, whatever you do, it's happened. And it's like illusion of control, or I'm blocking the when the child thinks that their thinking is influencing the outcome. Omnipotence control, yeah. Omnipotence control. The idea is that you have, like a child think, I'm thinking, something bad happened, and then it happened. They think they have this power to influence. So it's very high, when you're high ranking in the military, you have a lot of power, and you think you control, but nobody controlled the war zone. And he also for the transference, because his father was also like a high ranking, so always was yes sir, no sir. I say, I'm not in the military, I'm Ilan or Dr. Ilan, but I'm not yes sir, no sir, just the transfer is automatic, but the processing for him was, it's also the denial, of course, of fear. Because he was so high ranking in Iraq in the beginning of the war, people tried to assassinate him several times. Also the denial of anger. We talk about the anger, not just the fear, the anger. He trained one of the first Iraqi battalions. So sometimes the insurgent will kidnap, soldiers from this battalion of Iraqis. They cut their head off and they will leave the heads on the road that they will go. So he was internally so infurious, but he tried to pretend that fuck them, I don't care, I'm going to do my mission, I'm going to free Iraq. They have this idea that they bringing, and they don't realize also what happened, that when the power shift in Iraq is that a lot of Iraqi soldiers, when they felt the insurgents is gaining more power, the loyalty shift. They just moved to the other side. You train them, but they moved. And this has created a lot of frustration. And suddenly, like he said, one day he just took the battalion, the Iraqi battalion commander, they went for a weekend, and suddenly only half of the soldier came back. So he took this battalion commander, the Iraqi that he was training, threw him on the floor and started to scream at him. Like he lost control. He said, what's going on? And the Iraqis tell him, what do you want me to do? You want me to go and pick them up from home? He just couldn't control his emotional because of the situation. So, and what happened is that all those things were in the background of his head, and the war is going, and then there was an ambush for one, as a battalion commander, one of his platoon, 4 soldiers were killed, so they ran quickly to put roadblocks. And suddenly for one of the roadblocks, there is a pickup truck coming, and then the pickup coming and seeing the roadblock, and they doing 180 and going away. They stop those, immediately they stop this pickup, and they see a lot of blood in the back of the truck. But maybe they were they had few sheep. They say we slaughtered some sheep. We took it to the market. And in his head, he's thinking, those people killed my soldier. He started to frame, and then they he interrogating them and asking them, about what they're doing, and then eventually he lost it. So all the processing, without knowing exactly what happened throughout the course of time, you cannot make sense of it. If you just say, this is horrible, I know you killed 2 people, without getting all the information about people's life and what they went through, how you can process it? It's just one how you come into terms with it, You realize, those Iraqis, really, try to assassinate you several times. They send you heads of beheaded people from your unit. You understand that something was going on without the entire story and the way that he was thinking that he is in control all of the time. And then instead of realizing that he has limited control, he lost all control altogether and just killed those 2 Iraqis. So it's really important to have this long understanding. And I mentioned earlier today, you have to be modest, because most of you did not serve in the army. Most of you don't know a lot of the language. So say, just teach me. And when they say a word, I did X, Y, and Z, you need to say, what does that word mean? Don't pretend to know, because they don't trust you. You say, yeah, you're bullshitting me, you just want to treat me. Let them, when you're having this few sessions to know them better, before you start, let them teach you about what is the occupation, what they did in the military. Start with the childhood. Also object relationship, how they had, they might report relational problem now, but maybe they were never in romantic relationship before. Maybe there was other pre-existing things that cannot be separated. They always had difficulty understand other people. So it really makes change how you process the trauma. You need to go with them across this entire period. And when they go to military and they talk about equipment, they're talking about events, just ask. Let them, and when they're teaching you, suddenly they feel that they are your therapist, or they are teaching you. You are the student, they are the teacher. It's given them a lot of sense of power. Otherwise, they feel so vulnerable. So at least give them the sense that they can be very strong in so many ways. And just serving in a war but itself, it's something that you have to recognize how brave people have to do and not defect and not run away when you are suffering so much. So let yourself have. So we talk about every time that you go. So in sessions 3, I say don't make interpretation. I gave you some ways to make some interpretation. When you ask them to go over and over again throughout the session, after session 6, you started to focus on the trauma itself. So, when, let's say, I talked about this high-ranking person, he started to say, oh, they shot, there was fire exchange, they killed like 4 soldiers, we did a roadblock. Now we're focusing on the hotspot. The 5 minutes that he interrogate this 2 Iraqis, and those 2 moments, it's just that's the heat of the trauma, and just try to understand what's going on that moment, the most intense moment, and that's what you process. You don't have to go throughout the entire story. It's called the hotspot, okay? And just I remember what was very interesting with that high-ranking general, because there was under something else that is called undoing. Undoing, that you try to correct things that you have done. You did something very terrible. Because when he went back to civilian life, he got released from them. The first thing he did, he brought his interpreter to the US. He sponsored him for, just to create new life for this interpreter. But he worked on a very high financial, he was really high financial company that dealt with import-export. And what was worried is that he started to have thoughts that he wants to kill the CEO of the company. And I had to really be very careful, because, if you have homicidal, thoughts, you might want to report this person to it. But I was kind of on this understanding that is still kind of not at the way that I need to protect it. And what was happening, he realized that in the company that he was working, they buying certain amount of commodity coming to the US port. They need to test the material if it's good, and if it's past the test, you unload it and move it. But the company, because every hour a cargo ship is on the port, it costs a lot of money. So they say 99.9% that it's okay, let's unload the ship, the container ship, start to move the things out, and then we'll deal with it if we get negative, like hazardous result. And he said, this is illegal. This is like saving. He was so angry, but you understand it. Okay, this is okay, but that's not reason to kill your boss. It was driven by, he wanted to undo his killing by creating this bad things that was going on in his company. So it's created this tremendous amount of psychic energy that he was so angry at the boss, but actually he was very angry with himself. The anger that he projected to the boss was not actually toward the, yeah, it's okay, your boss is an asshole. You know, he's cheating the US government, he's, you know, doing some, but that's not a reason to kill him. This really like was this very intense anger that really was translated to that notion that he was because of the guilt that he was feeling toward what he has done. So processing that really like change and understanding how much anger he had towards himself that was then projected to the boss. So that's what really like the work that we're talking about and the integration of understanding everything that's going on. So again, we talked about those mechanism of transference. We talked about this patient that really I felt that we are like in the room with the, you know, with the mother that never talked. Was like, again, this patient that always called me, yes, sir, no, sir. Like I'm in the military with him or I'm with him with his father and trying to break it down to allow for the interpersonal relationship and again, using the defenses. Usually it's denial of fear and anger that really, and denial of the emotions. Everybody, most patients with PTSD deny all those appropriate emotions because they avoid it. Anything that reminds the trauma, they try to avoid. So that maintain that. Okay, so this is for a full day training. I will not go through all this training, okay? So I have 10 more minutes, no? So again, we can treat what is done now in the US. It's like this model that Noah presented, that you take the TMS, instead of carrying it during 6 weeks, let's do it in 5 days and do it, you know, 5 sessions a day. The notion was that, okay, prolonged exposure can be done in 10 sessions. Let's do it over 2 weeks, every day, 5 days, 1 session every day for 2 weeks. And people showed in comparison effectiveness that doing it every day for 2 weeks is as effective as doing it across, you know, 3-4 months. People are here on the unit. You can do it within 2 weeks and the effectiveness of the treatment remain the same. Unless people even leave the treatment, because it's very difficult treatment and things happen. So you just don't want to go. And I have a recording that of a patient, and they said, didn't ask to do it internationally, but when I do the training, he said, you know, I'm driving to the hospital and I say, why I'm doing it? You like want to drive and go home, but then they understand it's important and they just take a deep breath and calm, because it's very hard therapy to do. And recently in the last, with the help of Dr. Dweck and Dr. Rubinstein, we are condensing it to 5 days, actually. We're doing 5 days every day. And it's like we do the intake, the integration can take as long as it needs. Like you go into the operation, so it can be like sometimes the first session, when you come to know the patient, can take like 4 or 5 hours of sitting with them, taking a break, trying to understand and build a case formulation. And after that, every day, they're doing exposure therapy. And we put them in a hotel so they cannot go anywhere, and nothing happens between those days. Or if people here on the unit and getting new prostheses and they're getting adjustment, you can see them every day. And we just like our postdoc center, we have like almost 90 patients across this pilot and now, and we're starting with caps. It's similar to the PCL, around 40. And 30 days after the 30-day post the 1-week treatment, we see drop to 20 on average. And 90 days, we have 17. So it's a really like very strong result from the study. And, we have a weight control. We don't have the weight control because people sometimes wait because a month to get into treatment. So we show that the symptoms within the waiting period do not change. And then when they start the treatment, so working with them intensely. But again, you can talk to the therapist. It's not an easy things to do. You can't do 2 patients a day because it will be extremely, extremely hard. So, and again, not every treatment works for everyone. They have to remember. So those good numbers, there's some patients that did not improve. I think we didn't get people getting worse, although it's very intense. We got people that did not improve, but people did not get worse. So that's kind of safe. Do no harms, as the doctors say. I think we are in a good place. But again, not everybody wants to talk. And the capacity to do TMS, you can think how many people you can treat. How many people, and then maybe people, as Noah say, maybe if they not get better than that, then we can consider, continuum of care to move them into exposure therapy. Because again, it's not an easy therapy to do, but it works very well, I would say. It's worked extremely well. And again, I'm very strong, supportive of the psychotherapy. That's what I breathe and do every day. So hopefully you can help those soldiers that really stuck. And there is a lot of questions that will come when you do it. People did horrible things. People got to a lot of trauma, but we see it's working for all of them. Even we thought that people that went through multiple sexual assault by parents, how you process it. And those team of amazing therapists worked with those patients and were able to make them feel better, both Dorian or work with such patients. So, that's, I think, what I have. And I think it's really, the accelerated treatment can really work well when people are here in rehab and getting things done. And you have amazing team of clinicians here that really can help your soldiers to recover. And, thank you for doing this work. It's not an easy work. Thank you, guys.
Дякуємо, Ілан, за лекцію. Справді важка тема тільки для того, щоб вчитися. Я чую, як зал деколи дихає тяжко, коли це собі уявляє. І тут є з десяток наших терапевтів, які безпосередньо працюють з такими важкими пацієнтами. Ілан, я би хотів мати перше запитання до вас. Ми вчора трошки обговорювали вже це. Воно стосується комбінованої травми. Коли ми маємо пацієнтів з важкими переживаннями, пов'язані з травматичними подіями, і вони мають не тільки психічну травму страху смерті, але і моральну травму. Наприклад, зраду командира або приниження гідності. І іноді експозиція цих речей, тобі здається, буде ретравматизувати пацієнта ще більше, так? Бо це не є просто страх смерті, це є страх смерті, пов'язаний з моральною травмою. І інша коморбідна патологія, той самий страх смерті і посткомоційний синдром. Так. Які тактики ваша команда використовує в цьому процесі?
This is, again, very complicated situation, and I will not start supervision with you now, but it's really important to understand with the therapist, and if I'm taking the supervisors, to try to understand why Ole is so afraid to talk. What do you afraid of that would happen in your fantasy if you gonna talk about those events with the patient? They happen, correct? They're horrible. What is the fear that you have when you're thinking, okay, I'm gonna go over that story with the patient, with the betrayal?
Yeah.
What is
Страх базується на моєму страху ретравматизації пацієнта. Власне, з моральних моментів. І друге, з досвіду. Іноді, працюючи з пацієнтом в експозиційною терапією, пацієнт досить ефективно працює з травмою смерті, власної чи побратима, і раптом в кінці 5-6 сесії виринає моральна травма. Вона раптом стає такою великою, що ти не розумієш, адже ми ж попрацювали вже, так? І тут стає моральна травма дуже великою, яка викликає масу емоцій, переживань, страху. От питання є в мене, це є прогрес чи це є регрес відносин?
I think it's a progress. Sometimes there's regression in even in psychoanalysis. If you work with a narcissist, let's say, you need to create a depression that they are denying before you can work to build a new sense of self. When you think, so there is a rupture in the sense of self because you have done, let's say I'm the traitor. I had to trade to, I was a traitor, and I have to come to sense why I betrayed my people. And is it consistent with one personality, or it was induced by the unbearable situation that I went through, and I just wanted to survive. I wanted to live, and I need to live with that decision. And you have to make sense of that decision with the patient, why they made this decision and most of it is the fear of dying or being tortured so badly that they afraid that they cannot tolerate the torture anymore, so they will betray. But by not processing that, it always comes up in nightmares, conversation. So with all this pain, sometimes you need a regression, and people get worse before they can get better in this kind of very complex situation. But I think it's driven a lot of your fear that he will fall apart and cannot bring him back from that down, because some things is so horrible, and that's really, really big fear for any therapist to go through.
Ці переживання в мене виникли у лікуванні спеціальної групи людей. Це люди, які пережили новий для нас досвід. Це люди, які пережили тортури і полон. Ми ніколи не мали таких пацієнтів. І зустріч з такими пацієнтами, напевно, викликала і тривогу в мене або в нас, що ми регреснули, не вони регресують, а ми регреснули, напевно, побачивши те, чого ми раніше не бачили. І це для нас була травма побачити ці тортури, які вони нам з довірою презентували. Мені тільки що прийшла ця думка в голову, чому ми раптом почали боятися. Бо ми почали боятися. Я почав боятися, так правильніше буде.
I totally understand that, and I don't know, maybe again, this horrible war. I don't want to get political, but I had a soldier from Israel that went through that, and he said, "I cannot talk about what happened there. I'm just not there yet." And I couldn't treat them because they say, "I'm not there yet. Whatever happened there, I cannot talk about it yet." So sometimes the patient cannot go there yet, and TMS.
Yeah, now we have a panacea. And how
But
about,
sometimes-
як
but
щодо...
I'm saying just that the territory that you are going into, the level of violence and torture and things that your soldier are going through captivity is not seen for decades, and it's so hard, and I can feel for you. I'm showing off here, but maybe I will, I'm not seeing this patient, you're seeing them. You have to carry that. I didn't carry this load that you are carrying here, all of you. So,
Так, тут справді супервізії відіграють ключову роль. І щодо concussions, щодо коморбідної патології комоційної травми. Чому я це питаю? Тому що ми бачимо деколи, що пацієнти, які пережили декілька, десятків навіть контузій, легких ЧМТ травм, легких ЧМТ, вони неспроможні осмислити, так, або згадати події, які викликають в них посттравматичний стресовий розлад. І деколи ми бачимо, що вони не здатні брати участь в тій процедурі, так, бо ми так думаємо. І ми тому відсилаємо їх до нейропсихологів. Тепер будемо відсилати до ТМС. Чи ви бачили такі досвіди? Так? Тут важлива діагностика.
So again, the question, if you see that patient have no memory, I want to Dory because we talked in a supervision about the case that didn't have any memory of the trauma. So maybe I made a mistake. But Dory can talk to the case for a second. I told him, maybe you can run with the patient without, when you have this blank, if you imagine the worst scenario can happen, that will be your story. And is it true or not? I don't know. But because you live in a fantasy world and you can make fantasy about what happened and you don't have memory. So I say to Dr. Rubin, to Dory, just walk with the patient and what is the worst fantasy, what happened, and how he respond to that.
Yes, it was very helpful, and supervision is central for your health, also for the patients. Usually we don't treat in this system with TBI, like hard cases that lost consciousness for more than 48 hours. But in some cases, for example, in this case, it was someone who got dosed and lost his consciousness and didn't remember anything. You got robbed, you got molested, didn't remember anything from the event. But we are human beings and we need stories. So we had to find him a story. So we worked with what he had, and we completed the rest with the imagination. And you can work symbolically, even if you don't have a story. And also to connect between traumas, you can work with symbols that come back in different traumas. So eventually, after the supervision and intense week of therapy, he had a story with a beginning, a middle part, and an end. It all combined into his life autobiographical story. It made sense to him, and it made a big difference. We'll have to see in 90 days if the symptoms improved, but you can work with people that have no memory at all.
This is imagination about imagination. Ми маємо досвід того, що ми прибігаємо до допомоги нейропсихологів, які з допомогою спеціальних нейропсихологічних вправ піднімають активність виконавчої кори. І ми бачимо, що через 2, 3, 4 тижні пацієнти неймовірно згадують, так, події або почуваються комфортно з тим. І це деколи тобі потрібно навіть не 5 занять, а 3 заняття для того, щоб ця травмуюча ситуація стала вже в архівній пам'яті, а не в актуальній пам'яті. Ну, але це також цікаво, яке потребує дослідження, напевно, це поєднання. І ще одне, я вже з вами ділився, Ілан, що я особисто і деякі наші терапевти після кожної сесії експозиційної терапії, яка завжди закінчується симпатичною активацією, ми проводимо короткий 10-хвилинний стабілізаційний сеанс EMDR-терапії, які навчили нас колеги з Ізраїлю. І цей протокол називається КУЦ-протокол. Так? І це дуже ефективне. Так? Також потребує, напевно, дослідження, чи воно справді ефективне, чи ми так думаємо. Чи будуть запитання, колеги? Будь ласка.
Дякую. У мене коротке запитання. Я думаю, що ви якось про це вже говорили. Я так почула, що те, що ви пропонуєте, це можна робити прямо з діючими військовими, просто під час там якоїсь паузи в їхніх бойових діях протягом 2 тижнів. Чи так?
I'll give it this to Dr. Dweck.
Hi. Okay. So I think between deployments, I think it's better to, you must at least do some kind of processing of the events that occurred, preferably with their own unit. So this is what we do in the IDF, for example. We try to take the unit once it's like out of combat zone and build a story, a narrative for that unit. It's like 12, 20 soldiers together with their commander, and they build their own story that also helps with the resilience of the social support and the story about the unit. If a soldier is having some kind of PTSD response, something like that, for more than 2-3 months, I would go with some kind of that protocol for sure, yeah.
I think this is important for the army doctors in the audience, that they can think about when unit going out from the combat to get rest for a while to do this intervention that we're talking about. I think they have military doctors here, and that is really important for them.
In that aspect, I would say that those soldiers, again, like Ellen said to Oleg before, the story, the trauma, they already run it through that on a daily basis, right? With the intrusion symptoms, with re-experiencing. So we can do no harm in that aspect. The best case is that we will help them create a narrative. The worst case is that they will stay the same, basically, because they're already doing that. They're already thinking about that, sometimes talking with each other about those horrible things they went through.
І ще я хотіла уточнити, ми якби за військовими зазвичай сильно глибоко не ліземо, да, там, от максимум, наприклад, оці події, які там заважають жити далі. Просто я почула, коли ви розказували про цього командира, який застрелив 2 іракців, що ви говорили і про його стосунки з батьком. То от, чи це був вже, ну, тому що це вже був ветеран, і ви могли тому піти глибше, чи це взагалі принцип цієї терапії?
My didn't work. I didn't hear the question.
The question is the story about the commander and
Mhm.
killed two. It was a veteran, or this was a combat soldier, combat commander, and you, if it's a veteran, it's understandable that you can go deep. Yeah, talking about the father-son experience. If it's the actual soldier or commander in the battle, can you go so deep?
This particular person was already working left the military. He was I say in this high financial company was one of, but you can still go with soldier deep as you want. There's no problem with it. As long it's confidential, you know, even if.
Все залежить, ну, насправді я люблю слово казати, що це мистецтво. Мистецтво терапевта, його досвід чи її досвід. З пацієнтом можна йти, наскільки глибоко ти можеш собі це дозволити. Бо не випадково і всі кажуть, воно і так там вже є, гірше не зробить. Так? А якщо ти будеш ставитися з розумінням, повагою і будучи професійним. І, власне, це є, можна сказати, якщо терапевт уважний, він бачить, що пацієнт дозволяє і йде з тобою в цю глибінь. А якщо терапевт не бачить і насильницько хоче проникнути туди, то пацієнт також йому це покаже. Або загостренням симптоматики, або втечею, або оминанням. І це є мистецтво і досвід. І недаремно доктор Ілан говорив про те, що дуже ефективні є психотерапевти ті, які в минулому мали або мають психодинамічний досвід, і вони навчені балансувати між свідомим і несвідомим, між закритим, витісненим і реальним, ніж ті, які прийшли в експозиційну терапію з інших методик, які не передбачаються. Тоді, сказав Ілан, треба багато супервізій, інтервізій, які дозволяють тобі це мистецтво творити. Окей, ще. І ще одне. Є дослідження, які говорять про те, що якщо військові, які є активно в бойових діях, отримують психологічну допомогу, навіть якщо в них з'являються ознаки ПТСР ближче до поля бою, тобто не вивозити їх в тил далеко, а в межах там, 100 кілометрів, 50 кілометрів, тоді ефект від цього стає швидший і стабільніший. Ну, не знаю, принаймні такі дослідження.
I want to wrap with two stories about that from the battlefield. So on the one of the days following the war that started in Israel on October 7th, I came like on 2 days later to a location in Israel that was massacred to help soldiers who witnessed this massacre and were fighting for a couple of days. And I spoke with their commander. I told him, we need to talk with the soldiers. And he asked me, are you sure it's a good idea? Because they need to fight more. If we'll talk with them, maybe they'll break down. They won't be able to fight. They'll just want to go home. And I say, you know what? I'm not fully sure, but I think it's a good idea. And then I spent the day with them because we scheduled the conversation later that night. Still in a battlefield, right? In battleground. And I heard the soldiers talking with each other all day long. And what they described, the feelings, the seeings, the smells, whatever, was enough for me to be sure that we can talk with them because they're already talking about that between themselves. they're already very alert about it, and they even give themselves very bad advices for one another. So I think it's better for a professional to be there and guide them with that. So that's like my, I think, example of something like that.
І ще один дуже важливий компонент. ОР є військовою людиною. Так? Він є психолог, психотерапевт, і він є військовим. Тому так важливо, ми зараз це робимо в нашій клініці. Ми закликаємо ветеранів, які вже вийшли з війська з тих чи інших причин і мають здібності до цього, часткову освіту, іти і вчитися на психології і психотерапії, бо це зовсім інший шлях до довіри у тих, хто воює, аніж цивільні психотерапевти, які мають цей шлях. Він є цей шлях, але він є трошечки довший і більш такий складніший. Тому навіть в цьому залі є хлопці, дівчата, які пройшли серйозні комбатантські події, і не тільки комбатантські, і на сьогоднішній день вже вчаться на психології, психотерапії і психіатрії. Тому це важлива наша задача, чим більше таких фахівців мати. До речі, також приклад Ілан, я дуже гордий так це чути. Ілан сам в минулому військовий, але будучи дослідником, професором, лектором, він кожного дня бачить пацієнтів. Він кожного дня з ними разом. І тому вони йому несвідомо чи підсвідомо довіряють, і він їх так розуміє. Це дуже важливо мати практику. Дуже важливо мати практику і супервізію. Ще. Я прошу, Світлана.
Коли ми запрошуємо клієнта зайти в експозицію інвіво, наприклад, піти в страх, і він боїться там масових місць, але ми кажемо, сходи в супермаркет чи кудись, він мусить це зробити самостійно, чи можлива якась допомога, підтримка йому?
As long as they go, I think it's fine to start with someone. If he will not be able to do it alone, he will not go. And if the first stage, we're doing it in research, so right now we make sure that they go, and we have a research assistant going with them. But in the clinic, we just ask them to go, and if they want to go with a friend at the beginning, and they start to feel safe, and then after like few times that they go with a friend, they go by themselves to the crowded. As long as it's consistent that they not avoid it, that's the most important. You know, I remember I had a soldier that was in Lebanon. A truck that exploded the Marines building, and it collapsed. Probably it was 84, I don't remember what year. So everybody, you know, a lot of people died, and he saw, you know, a lot of people bodies going, and you know, every time that he saw a truck, he was just getting panic attack. And I say, you know, sit next to like a rental company that had a lot of trucks, and he was just sitting, and he said he was afraid, like he was sitting and really almost in panic attack, but he could continue to do it. And one day he say, it's just gone. I had an insight suddenly, like it was, I'm here in the US, this is a rental company. Sometimes we don't know how the insight go. Like we have this whole inhibition that you say, okay, relax. He was really occupied with say, okay, relax, I'm okay. I'm in a Dunkin' Donuts. It was Dunkin' Donuts where he was sitting across from the rental company. And he was very anxious. He had to fight it. But suddenly there was an insight. Something in the brain flicked, and he created a new understanding, a new memory of a truck. There is a truck in Iraq. That was in Lebanon, a truck in Lebanon, and there is a truck here in New Haven, that it's clicked and you say, wow, suddenly it was just, but you have to be consistent, because if you were sitting, okay, it's not dangerous, I'm going, it's too much for me, it's just reinforced. So you have to really be, it's very not interesting psychotherapy, but this is a small part of the therapy, but you need to do it, because otherwise this overgeneralization of fear, you expanding the fear circle, it continue to affect your life, and you continue to avoid things. So yeah, it's fine to go. Long question. The answer is yes. One word.
Дивлячись на те, що ця терапія є дуже, як ви бачите, така технологічно протокольна, так, є дуже там протокол, але поза межами і в протоколі написано це одним словом: якщо не сформовані довірливі відносини між психотерапевтом і пацієнтом, нічого не станеться, або станеться це в довший період. А довіра будується не протоколом, так, а стосунком в терапевтичному процесі, так, в сетінгу, в рамках, в довірі, в переживаннях. Так. Дуже добре сказав Ілан: я дозволив собі заплакати, але я пояснив пацієнтові, що це не моя слабість, а це сумна історія. Бо пацієнти, насправді, ми мали декілька випадків на супервізії наших, що пацієнти побачили страх в очах і сльози, і сказали: слухайте, це про що ми тут будемо говорити з вами? Ви тут ні черта не знаєте, не можете і не хочете. Тому стосунок і альянс, і довіра є критично важливими. І поки ви цього не відчуєте, йти глибше, просто важко. Але для цього треба досвід, супервізія і знову досвід і супервізія. Ще є? Yes.
Thank you. I'm very happy to see you again here. Thank you for your hard work. And I have a question. As you said, we know that hypervigilance and suspiciousness is one of the symptoms of PTSD. But in our war and in our reality, the threat and the reason of suspiciousness can have the real obstacles and real circumstances. So what would be your advice to clarify the difference between the reality and the imagination of the patient, and how to overcome it?
Thank you. I think the notion, if the stressor is still there, it's very hard to diagnose PTSD because the stressor is still active. So it's the end of, but we're not going to stop diagnosing PTSD now because the war is 3 years now. And this suspiciousness and hypervigilance, so if the soldier is out of the war zone and with his question, it's a good question because you don't have the 30 days, but if you allow, let's say, differentiate along, I'm just making up, let me organize it. My sense, without going to the diagnostic book, is that if I go and can shut down the stress in some areas in my life, and I can enjoy them, and although there is a war going, but now I'm with my mother and drinking a cup of tea, and I can let things down and relax, maybe I'm okay. But when I get closer to things that are really stressful, I should be stressful. It's a war. But now when I'm going to the definition of prolonged stress, I might carry and drink tea with my mother and be very stressed because it's less than 30 days and I'm still suffering from acute stress reaction. So it's really tricky here. Or you're working with a lot of nothing to. yeah, again, I think the reassuring for therapy, if someone say, okay, I just got 30 days off, went for refreshment, they took me out from the front line, went home, I have still intrusion, I see things from the world, but 5 minutes, I sit with my mother and, my girlfriend or my friends in a bar and I can laugh and relax. I think I'm okay, but if I just non-functional, that's a red flag for me. I just cannot let anything off. But the war that continues, I don't know for how long. Who can predict? Maybe God, but I don't know when it's going to end. And just you have to trust your guts, what the patient tells you, and what you think. Okay, that seems reasonable. Yeah. Being stressed, thinking about your friends that in the front and worried about them. But you can let go for a few minutes and sit down and you're okay, I think, I remember, being sad and upset, it's a normal human behavior and we should not take it. It's a horrible situation. And your friends are in the front and you can be stressed about that. But if you can get some good time sometimes, you're in a good place.
Дякую. Ще маленький приклад цього. Пацієнт, який пробув 90 місяців в полоні і пережив сотні принижень, і вийшов з полону і потрапив до вас в перший тиждень після того, як він вийшов з полону, ви на нього будете дивитися і точно не будете говорити, і не будете спонукати до того, що він говорив з вами про події, які з ним були, бо він щасливий. І може щастя закінчиться через місяць, чи через 2, чи через 3, як ми спостерігаємо. І він прийде, або його дружина разом з ним прийде, і тоді їхні спогади будуть. Це багато досвіду нам потрібно навчитися. Терпеливо, дуже спокійно ставитися до потреб пацієнта тут і тепер. І якщо пацієнт надмірно оминає, то ми не повинні лізти і витягати. Ми повинні створити умови і обставини, у яких пацієнт сам знайде простір довіри і піде разом з нами. Окей, ми мусимо закінчувати, колеги. У нас сьогодні інтенсивний день. Дуже дякую, Ілан, за лекцію. Ми, як я вже вам казав, зараз вже команда побудована, і ми готуємо лекції і практичні заняття з експозиційної терапії, які будуть відбуватися в нас в центрі. Про вас буду вам це доповідати, щоб не тільки теоретична лекція з важливими практичними зауваженнями, але і безпосередньо тренінг експозиційної терапії, який, напевно, є найефективніший на сьогоднішній день. Завтра у нас буде 3 групи. Найбільша група – це група, яка буде працювати з моральною травмою, а післязавтра з травмою, з суїцидальними думками, їх профілактикою і лікуванням. Група, яка буде працювати з Ноа і Мартін. І всі приходять сюди, і ще одна група буде працювати з ОРом, функціональної ФМРТ. Всі приходять сюди, ми потім розділяємося на ці 3 групи. 2 маленьких і 1 велика. І завтра працюємо цілий день з моральною травмою тут. Тому всім дуже дякую, бажаю успіху і спокійного... будь ласка. Хвилиночку.
Сьогодні звільнили з полону бійця мого чоловіка Данила Єршука, позивний поліція, який там пробув з січня 23-го року.
Це справді подія, яка є дуже важливою. Тож побачимося завтра, колеги. Побачимося завтра. Все щасливо. Дякую вам за увагу.